Okay, hello everyone and welcome to our webinar tonight. My name is Shelley Korean and this is the July edition of SkyPass Foundation's Ask the Doctor webinar series. I see some familiar names on the attendee list, but for those of you who are new here, SkyPass Foundation is a nonprofit. We're based in Dallas, Texas, and we specialize in providing resources to the PD community. And we do these interview style webinars on a wide range of PD related topics. And tonight our topic of discussion is atypical Parkinsonian disorders. And I'm happy to welcome Dr. Irene Litvan from UC San Diego, who is here to share with us her expertise on this topic. Dr. Litvan is a board certified neurologist and director of the Parkinson and Other Movement Disorder Center at UC San Diego Health. Dr. Litvan treats and diagnoses individuals with Parkinson's disease, PSP, Huntington's disease, essential tremor, and other movement and dementia disorders. Her research focuses on a better understanding of Parkinsonian and dementia disorders and novel therapeutic approaches, including symptomatic and disease-modifying therapies, as well as novel technology for better treatment and management of these diseases. She's a fellow of the American Academy of Neurology, a fellow of the American Neurological Association, and is an internationally recognized expert in movement disorders and dementia. Dr. Litvan, welcome to our webinar. I know our attendees have a lot of questions on this topic, so we are excited to chat with you about atypical Parkinsonian disorders. We also have with us Dr. Shilpa Chitnis tonight, SkyPass Foundation board member and a movement disorder specialist at UT Southwestern. Shilpa will be interviewing Dr. Litvan on our chosen topic for tonight. And if you're joining us live on Zoom, just a quick reminder that you can interact with us at any time throughout the conversation using the QA box or the chat boxes at the bottom of your screen. And we will try to address all of your questions and thoughts towards the end of our time together. And with that, Shilpa, I will hand it over to you.
Thank you so much. And it's a great pleasure really to be able to be interviewing Dr. Litvan, who is really one of my early mentors and has really influenced my career in many ways. And we worked together on a number of different initiatives, both at the AA and MDS. So I'm super happy that you could join us. So we'll start, I guess, with some very basics, and maybe you can tell our audience what is meant by atypical Parkinsonism and how does it differ from our, garden variety Parkinson's disease?
Well, first of all, thank you very much, Shilpa, for inviting me. It is always a pleasure to participate in whatever it is that you do. You're incredible, productive, and also working all the time. And I'm happy to support any projects that you are doing. So let me answer that question. So what is an atypical Parkinsonian disorder? It's an excellent question. It is patients that do not have the typical response to medications that patients with Parkinson's disease do have, and that they do have other features that are not present at all in patients with Parkinson's disease. But the commonality, though, is that both patients with Parkinson's and with atypical Parkinsonian disorders, they have Parkinsonism. And Parkinsonism would be like furniture, it's an overall category. And then you have the different items there as if you were having chairs and desks. So here we have atypical Parkinsonian disorders and we have Parkinson's disease. And the commonality is the slowness, stiffness, and tremor at rest. Those are the main features that are common to both. All the others that I will be referring to are atypical, such as progressing very fast, having falls as the starting of the illness, or severe balance problems, having problems moving the eyes up and down, having very low blood pressures when one stands up, what we call orthostatic hypotension, having lack of benefit from dopaminergic medication. Patients with Parkinson's have a beautiful response for many years, and in general, they do have it. It's just that the medications don't last long enough to provide all the benefit that patients could have. But here the difficulty is that in general, patients do not respond. And when they respond, the response is more moderate and is not long lasting. So those are pretty much the major features that differentiate the disorders. And that's why at times they were called like Parkinson's plus, because they had many other features. But I think it's a better name calling atypicals because they are not the typical Parkinson's disease disorder.
That's a great explanation. And so can you name for us what constitute the atypical Parkinsonian disorders?
So there are several of those. The most common and known is progressive supranuclear palsy. In this disease, the major problems is the difficulty moving the eyes up and down voluntarily, but you can move them when you do what we call the doll's head maneuver. That is, the eyes move spontaneously because the lesion is not at the level where the nuclei of the motor nuclei that relate to the movement of the eye, but it is above, and that's what is called supranuclear. And the difficulty then is moving both eyes up and down initially, and then that may advance. There are earlier features that are not just the eye movements, and the most common one is, for example, having significant instability, falls very early in the course of the illness. But there are other presentations that we have learned with time, and some people may develop, for example, problems with language, and they may have difficulty expressing themselves. Other people may have problems with what we call executive function. That is the function that has to do with multitasking, that is planning, etc. So that is, in a nutshell, although not all the features I mentioned, some of the main ones that have to do with progressive supranuclear palsy that we call PSP. Yes, go ahead.
Perhaps you can name them and then we can talk individually.
Oh, okay, perfect. So the other ones is multiple system atrophy, that is also very frequent, corticobasal degeneration. The other one is dementia with Lewy bodies. And there are familial also disorders that are atypical, that may have frontal features and Parkinsonism. Those are even more rare than the ones that we're talking about right now.
Yes. Okay. So sorry to interrupt. So let's take each of those individual ones and we can talk about perhaps your favorite one, which is progressive supranuclear palsy. So perhaps you can tell us some clinical features and how you make the diagnosis.
So I mentioned about two of those that are very significant ones. One is the postural instability. The other one is the problems with the movements of the eye. That is basically what makes the diagnosis. Without that, it is very difficult to make the diagnosis of PSP. But there is also problems with speech and swallowing very early. There are problems as well with what we call executive function as well. And there are problems as well with not responding well to the medication that is levodopa or any dopaminergic medication, Cinemet or Rytary or whatever it is that you could think of. So how do we make the diagnosis? We make the diagnosis following certain criteria that are based on the main features. And the main features are the eye movements, the Parkinsonism that doesn't respond, the postural instability, and the cognitive problems, mostly the language problem or the frontal disturbances. But all of them have to have eye problems with them in order to call them PSP.
Yes, absolutely. So in terms of treatment, what are current approaches to overall management of PSP?
So for me, the important part is to think that we have a lot to do because we have a lot of systems that are not working. So we want to make sure that the person doesn't fall. So physical therapy is one of the major approaches, and the first one that one need to think about, because we want to make sure that someone doesn't fall, because falls lead to fractures. And the idea here is always of prevention of symptoms to get worse. So that is the first one. And if the balance is significant, it is important to use something like a walker. And the walker that can be used has to be a weighted walker. It should never be a cane that some people start with that, but then you need to realize that most people with PSP carry it as an umbrella. And so that doesn't work. And so it is important that the person uses a walker, and that walker be weighted so it is really something that they can support themselves well. And they need to learn how to use it. So there are several in the market that they need to use, and that is very important, because I want to say that Medicare pays for only one walker every 5 years. And so if you get the wrong one, you're really stuck. So if you're going to buy something that is, you're going to get something that is very cheap, buy it yourself and get the real ones paid by Medicare. Well, that's one thing. Then obviously we need to make sure that people don't have swallowing problems. And if there is coughing with liquids, we need to do a modified barium swallow. And then that leads to modification of either the diet, the posture, the consistency of the food, or perhaps minimal things that are just using some other way of eating, like a chin tuck position or whatever. So it is important that that is done, because actually the major cause of death is aspiration pneumonia. So that's why I always say the two major things that we need to work on are the postural instability, and also we want to work on the swallowing problems. There are other things like, you know, the eyes are dry because people don't blink enough. So natural tears are important. It may well be that there is importance in improving the speech. And so speech therapy may be needed, or occupational therapy for changes in positions, etc. I think that there is a lot of treatments, but those treatments are needed based on the symptoms that the person has.
Yes, absolutely. And so just to dwell a little bit on any current research or any therapy. So I was going to ask you, medications such as Azilect or valproic acid, coenzyme Q10, any premise for any of those medicines?
Well, the first medication we use is truly the Cinemed, and we go to very high levels. And we try to do at least a trial of a month, and we try to get up to almost 900 milligrams to 1,000 milligrams of levodopa, with the idea of really trying to see if early on there is any benefit. But if there is no benefit, there is no benefit in having a medication that may have side effects or that is really not needed. And so then you're starting to accumulate medications that are worthless. So we really are quick in trying the medication when there are Parkinsonian features that we want to improve. We don't use much of Azilect. Some people use amantadine, or they may actually use selegiline for the postural instability that some people believe that may be helpful. In my experience, that hasn't been so helpful. But there are no trials, unfortunately, that can really tell us what is the best medication. And most of them are, what we really try to do is make sure that we don't use medications that can really worsen someone. For example, anticholinergics. Those we really try to make sure that people, even if they have some kind of a tremor, they don't use, because cognition can get significantly impaired.
Yes, absolutely. What about some of the, antisense oligonucleotides and some of the tau, antibodies that some of the companies, Denali and AbbVie, et cetera, are developing?
So that is a wonderful question as well, Shilpa. The major advances is the use of antibodies that can try to slow the disease progression, with the idea, and I'm not sure if the people that are here have heard some of how the disease progresses, but just in a nutshell is what we call the prion-like progression, how the disease spreads from one cell to another. That is like the normal protein that exists in all of us, and is the one that helps with the border of the cell, the membrane, and that protein is called tau. That protein is very important because it is what surrounds the cells. It is also what forms the pipes that nourish the cells. And in PSP, that protein agglutinates, kind of changes its shapes. And as it changes its shapes, they change also the function. And so let's say that the protein was like this and it changes like that. And so the next protein, that is tau, also by contact also changes its shape. So as the neurons communicate from one to another, these abnormal proteins that bind to each other go from one cell to another, and the disease continues to spread following pathways that have to do with the normal pathways in which the cells communicate with each other. So antibodies, as if you can think about COVID, similar mechanisms in some ways are being used to try to scavenge those abnormal proteins, get them out of the body to decrease the possibility of spreading of the disease. There have been 2 trials searching for one aspect of the tau that was one of the ends of that tau protein, but now there are new ones that are going to the other end to try to see if that one that has more relevant aspects of tau could be the one that would be more effective. So that's one of the antibodies trials that is being conducted. And the other trial that is extremely exciting as well is with antisense oligonucleotides. And in this trial, it is the formation, or it goes against the RNA that transfers the information from the DNA to a protein. And because it is abnormal, it forms abnormal proteins that are the ones that I'm telling you that are going to be changing their shape, and they're going to be binding with each other, et cetera, et cetera. So the antisense oligonucleotides would work against that abnormal messenger RNA, trying to make sure that there wouldn't be any new proteins that are abnormal. So that is a completely new mechanism, an approach that has not been used ever in PSP, and it's going to be used now. And so it is exciting to have two trials on something that may be a way to go. So it is a pleasure to think that we're really working hard in not only treating symptoms, but also trying to slow the disease progression.
Absolutely. I think therapies are now going to go from, symptomatic to molecular, which is fantastic, or even genetic, like, in some disorders. So Corticobasal syndrome, is that one entity? Is that many entities? How are they different from PSP?
So Corticobasal syndrome would be like, it is really a clinical presentation that is like having problems moving an arm. One loses the ability of really learn how to do it. Even if one knows that wants to do it, the arm doesn't kind of respond. So that's kind of what we call apraxia. So these patients develop in one side apraxia. They may develop dystonia, like it's an abnormal posturing. They may develop the Parkinsonism in that side that also hardly responds to levodopa. And they may as well, obviously, develop the problems with speech, the problems with swallowing, the problems with walking. And these abnormalities go from one side of the body to the other. That's kind of what we call, in essence, Corticobasal syndrome. It could have also cognitive aspects, such as the presence of language disorders, aphasia, difficulty talking, having like not being able to remember the words, having difficulty finding the right word. So all those features are part of the same. The thing is that initially we thought that all those patients would have as underlying pathology, that is, when we look at the brain, the abnormal protein would be tau. But what has been discovered over these past years is that unfortunately that's not the case. And so the abnormal proteins could be tau, but it could be also other proteins, such as the protein that exists in PSP that is different. The tau is a different tau than the one that is in corticobasal degeneration. It could be a tau that is different, and there is like in Pick's disease, another disease. It could be even Creutzfeldt-Jakob disease. It could be at times even multiple system atrophy. Anything can be, honestly. Even syphilis has been found as affecting that areas of the brain. And so what really happens is that certain areas of the brain respond, and for whatever reason seems to be more susceptible to be affected by these different etiologies that lead to different proteins aggregating in that area. So it is a disease. Corticobasal degeneration is a disease, but it's a disease that presents with different presentations, as in PSP. In fact, some of the presentations overlap, and at times it's challenging to differentiate alive one disease from the other. It is easier, on the other hand, to differentiate corticobasal syndrome due to tau than due to Alzheimer's disease, that is a common underlying pathology, or it could be other frontotemporal dementias. All that can be ruled out by doing some lab work. And that is part of the diagnostic criteria, not only to find the positive things that define the symptoms, but also ruling out, excluding other diseases. And Alzheimer's disease is one of the main ones that needs to be excluded because commonly may present in the same way. I don't know if that was clear.
No, that's excellent. That's actually exactly what I was, thinking. So do you think, so basically if the tau protein is, different between PSP and Corticobasal syndrome, that you would not imagine that the same treatments that are being considered for PSP would work for CBS, you think?
That's what we thought originally, but now that there is what is called the cryo-EM, that is an electron microscope that can see exactly how these proteins are constituted in the, in an incredible way. I think it's angstroms, micro angstroms. I don't know exactly what the measure is, but it's extremely, extremely small. And so you can actually see the actual fibers, and happens to be that they are different. So there were characteristics that made us think that they were different, because when you look at the pathology wasn't exactly the same. Both of them are what we call 4-repeat tauopathies. That is, they have the same overall areas that are affected. But there seems to be that the strains may be different. And when you look at them in this cryo-EM, they're certainly different. So corticobasal degeneration strains have been clearly identified, and they're basically all the same in different people. But it has been really hard to find a commonality of those strains in PSP. So far, when they are looking at the brains, I don't know if it is related to the different presentations of the disease, or it is related to something else. But the basic scientists are having difficulty really identifying those strains, but clearly they are different. So one wonders if the same antibodies or the same antisense oligonucleotides would work. But I think it would be important to use those because perhaps they do work. And nowadays that I think that the criteria has improved, it would be very relevant to start really diagnosing and being able to enter these patients into a trial, because there are not so many trials in patients that have this corticobasal syndrome.
No, absolutely. And in talking in terms of, corticobasal syndrome presenting almost like Alzheimer's disease, what do you think about the very controversial new Alzheimer's vaccine that just got FDA approved?
I think it's a disservice, honestly. First, it was approved for everybody that had Alzheimer's, but the studies were done only in very early disease. So that was, the drug is extremely expensive, has a lot of toxicity. If everybody that has Alzheimer's would start using it, it would be a major catastrophe for the rest of the healthcare system. And honestly, it isn't clear that it truly works because the changes have been minimal and not consistent. So I don't think it was a good idea. There's many more things to say, but
Right.
at least in essence, those would be the main ones.
Yeah, and as you know, there's a couple of FDA officials that actually quit after the approval of the drug. So, I think they just needed to get like something out there because they've been working on something, and I think it creates false hope for patients. So I'm in complete agreement with you.
Yeah, I think the false hope is the worst that can happen.
Okay, so we can now switch gears from the tau protein and talk about the atypical Parkinsonian disorders, which is a proteinopathy of a protein called alpha-synuclein, as we also know is involved in Parkinson's disease. So let's talk about a disease that's considered to be a very common mimic of Parkinson's, especially in the early stages, and may also respond to levodopa, but again, you lose the response to levodopa. So that's called MSA or multiple system atrophy. And so maybe we can talk about the clinical features of MSA and why it is called MSA.
So the clinical features affect different systems. And just because of that, it's called multiple system atrophy. So what are those systems? One system is the one that has to do with the motor aspects. And in the motor aspects, it could be two different types, either Parkinsonism or it could be the cerebellar type. So if it is Parkinsonism, it would be the same features that we see in Parkinson's disease. But it could be asymmetric or not. But one feature that is different than Parkinson's disease is that there is postural instability early on, within the first 3 years. That is not seen, as we said before, in Parkinson's disease. When we see that in Parkinson's, it's really late. It's 15 years after the disease has started. It's not really an early feature of the illness. So Parkinsonism, in 30% of those that have that presentation, they do respond to levodopa. Not as well as in Parkinson's disease, that all the symptoms disappear for several years, but what is called the honeymoon of Parkinson's disease, but it is responding in significant ways as well, but with some, usually some abnormal features that are there. The other motor aspect could be the cerebellar presentation, and that cerebellar presentation is with a wide base gait, with incoordination, and here it is different than what the gait and the features as it is in Parkinson's. But then there are another system that is involved, and that's what we call the autonomic system. And that system is related to the nerves that go to the different organs. For example, and two of those are very important, is the the GI system, for example, that could be severe constipation. It affects as well the control of the contraction of the arteries. So when we stand up, rather than having a high blood pressure as we all have, there is a low blood pressure. There is what we call orthostatic hypotension. There is also involvement of the bladder. And so there is what is called the neurogenic bladder. And that bladder in general is small, So there is significant incontinence. And at times there could be retention of urine. It could be a big bladder as well, but that is less common. Those are major features that occur very early in the course of the illness. In general, may precede. There could be also early erectile dysfunction in men, and it could be usually the first feature that could be followed by orthostatic hypotension, and then the urinary problems, and then the motor problems. So that would be in general, the kind of sequence of events that you see in multiple system atrophy that presents with Parkinsonism, that is the one that is confused with Parkinson's disease. And why is it confused? Well, because it responds to levodopa, and because at times in people that do have Parkinson's disease, there may be some autonomic dysfunction, but it's very mild. It's not as severe as what we can see in multiple system atrophy. So I think that is what makes it complicated. And so if people don't ask, the patient may not tell. And so I had patients that I have seen that were diagnosed with Parkinson's, but nobody had asked them about erectile dysfunction or urinary function. So they missed the boat because the patient didn't know. How would they know that that was something that could have been related? Or if they had syncopal events, I mean, if nobody asks, maybe someone cannot think that this is part of the same problem. So I guess it is important for the patient to say everything and for the physician also to ask everything, so we can really come up with the right diagnosis, and particularly to get the timeline of events. That is what really helps us to come up with the proper diagnosis.
Absolutely. And I'll tell you, one of the embarrassing moments for me as a physician in clinic is you have an older person and their wife there and the children are there. And, and essentially I had to ask them about erectile dysfunction. And so I basically say to everybody, sorry to embarrass you in front of your children, but, I have to ask you this question. And do you have any erectile dysfunction? And, and then they're older as well, right? So it's sometimes hard to distinguish whether it is an age-related or a disease-related thing. So I hear you. So there is, right now in the MSA community, quite a bit of curiosity and enthusiasm about the Biogen drug, verdiperstat, which is, I guess, now in phase 3 clinical trials, and the complete data is expected to come out by the end of the year. What are your thoughts about that?
Well, that is also exciting because it's an antisense oligonucleotide. So it is a different way of trying to see if we can decrease the production of alpha-synuclein that is abnormal. So it is a lot of hope to think that you could stop the disease progression by not having any more abnormal protein. So if that works, that could be like other diseases in which we know that antisense oligonucleotides do work and have marvelous results. Fortunately, in one of the other movement disorders that was Huntington's disease, that was not seen, even if we had a lot of hope. But I guess it's a question of keep trying. I never give up. I think that is important to continue because success only comes from keep trying.
Yes, absolutely. And for the audience, one of the things I really want to mention is, why is it very critical to make the diagnosis of atypical Parkinsonism? Number one is the prognosis is quite different, from Parkinson's disease, which can be a, 25, 30-year-old disease. But the second reason also is, because one of the things I do for a living is deep brain stimulation, and I really pay very careful attention to these patients, especially the MSA patients, for the first, 3-4 years, because I have had enough people with MSA that got implanted with the DBS stimulator. Dr. Litvan, I'm sure you've gone through that experience in your career. And then when they don't respond, and it's really heartbreaking, they say, I heard you're an expert in DBS and you can fix everybody, so fix me. And certainly I can't, because, they just, this is not an indication. So I think that, I guess even the FDA rule for 4 years, at least, my personal rule is about 5 years, that by 5 years, if you're still levodopa responsive, you're not developing atypical symptoms, then I think you could possibly be, safe to do, especially with, us talking more and more about early STEM, early DBS in these patients. So that's wonderful. And so last but not the least, let's talk about dementia with Lewy bodies. And what can you tell us about that?
So dementia with Lewy bodies is a disease in which either dementia happens first and then the Parkinsonism occurs, or both the dementia and the Parkinsonism may coexist at the same time. So it is clearly different than Parkinson's disease, because in Parkinson's disease, there is no dementia, at least early on. There could be dementia, but it occurs later. So dementia very early, and particularly, it is being defined as within the first year. That's more a definition made by humans than by biology, but it's still, they coexist, and particularly within the first 1 to 2 years of both things is certainly something that suggests that someone has dementia with Lewy bodies. And what are the clinical features? So the cognition is impaired, but it's impaired differently than in Alzheimer's disease. This is not, if it's not associated with Alzheimer's disease, this is not a dementia that we see like the one in Alzheimer's disease. Here, the major problems are frontal. And at times, those are so difficult to figure it out, because patients, all my patients are very intelligent, and so they can keep up a good conversation, and they can overcome all the features that would suggest that they have dementia. In fact, I have students coming and saying, why are you saying that this patient has dementia? And so when I show them the testing, they can see that they have problems planning, they have problems sequencing, they have problems copying a design, they have problems with the fluency of words, they have problems because they become much more loose, they are being abstract, so the conceptualization is lost, so they're more concrete. And those things are seen in real life if you're planning, if you are the one that is multitasking, but if you're not, that may not be observed at all. So you can see it more in your testing, and then you can see it in how the person is not able to do things that they used to do, such as driving, that is unrelated to the motor problems, such as shopping, because they're not able to figure out what is the change that they were supposed to get, for example. So all those features that are not seen in a general conversation, but yes, they're seen in what we call the instrumental activities of daily living, that is, activities that are more complex. So that is there. And in addition, there is hallucinations, the presence of what is usual visual hallucinations, seeing things that are not there. Because they are not threatening, people may not really report them, and they may just see passing by people or passing by animals or a dog or a cat, but may not really realize that that is an issue that is, or if they realize because it doesn't bother, they may not report it. So again, it is important to report everything that happens that is new. And it's important as well for the physician to ask those same questions. So those things are very relevant. In addition, one thing that is in Parkinson's disease, enacting of the dream. So normally when we dream, we don't move. But here in Parkinson's disease and also in dementia with Lewy bodies and also in MSA, we enact the dreams. So when we dream, we start moving. And so if the dreams are violent, then we start fighting and we may hurt our partner or we may fall out of bed. But those features are also seen in dementia with Lewy bodies as well. They may also have some autonomic disturbances, orthostatic hypotension, for example, and even urinary problems may be there as well. So there is a variety of features. And one thing that fortunately not many people are using any longer is the use of neuroleptics, particularly the old neuroleptics in people that have hallucinations, because those they're really badly tolerated in people with dementia with Lewy bodies, but they're not well tolerated in people that have Parkinson's disease either. So those are medications we should avoid to start with. So those would be the main clinical features of the illness. So it would seem as it's the same Lewy bodies that exist normally in the back of the brain, in the brainstem, in the substantia nigra, and other areas of the brainstem, and even starting supposedly in the gut, going all the way up. Here, instead of going all the way up, they are already up in the cortex. So that's why all those symptoms that we don't see early on in Parkinson's and may not see in Parkinson's, those symptoms are there early on here because it seems like it starts from the cortex and also in the substantia nigra. So it may well be that it goes downwards rather than upwards.
Absolutely, and it's a very excellent explanation. And so one question I have is, none of these disorders, Dr. Litvan, have any genetic basis, do they? I mean, none of these are predominantly genetic. Can you think about?
Well, yes, there are genetics. For example, the triplications of alpha-synuclein can give you families that have dementia with Lewy bodies. So the duplication gives you more the Parkinson's type of families, but the triplications gets you to more to the dementia with Lewy body families. So yes, there are some genes that can present in this way. I'm not aware if GBA may be the one that also presents like that. You know, certainly we know that Parkinsonism associates more with dementia with this mutation, but I'm not aware of families that may have that mutation, but perhaps there are some.
Yeah, thank you. And just, some other disorders that you talked about is frontotemporal dementia, but even like, juvenile Huntington's disease or certain spinocerebellar ataxias can present with Parkinsonism. So can you just briefly touch on that?
Yes, Huntington's disease in the early presentations, when the presentation is early on, when you're, a kid, when you're young adult, then instead of having all the chorea, you may have the Parkinsonian features of presentation. So Parkinsonian presentation very early in life, it is a possibility of having Huntington's disease, particularly when it coming from father. Then there are ataxias. These are families, particularly spinocerebellar atrophy, that is 17, for example, may present as well with Parkinsonism, that is exactly the same as Parkinson's disease, but may also have some atypical features. So some of them may have atypical features, others may not. As well as some of the mutations actually may have some atypical features that have been described, cases of LRRK2 that present with an MSA phenotype or PSP phenotype or presentation. Phenotype means really presentations, clinical.
Absolutely. So I think those are all my questions. Thank you, Dr. Litvan, and I'm gonna look at the questions, from the audience. I guess Mr. Davis, Dr. Litvan did answer this, but I'll just read it out. I'm confused as to the difference between Parkinsonian and Parkinson's.
The Parkinsonism is all the diseases. Would be like furniture, right? Furniture could be any furniture that you can think of. So it could be the desk, could be a table, it could be a chair, right? So Parkinsonism is everything, not one disease. It's just many things. Like if you would say pneumonia, right? So pneumonia is a disease, but it doesn't tell you what is the cause of the disease. Is it a disease of bacteria? Is it a disease of fungus? Is it a virus? What is it? So that is the same as Parkinsonism. And within Parkinsonism, then we have Parkinson's disease, that is the most common Parkinsonism. And then we have the typical Parkinsonian disorders that are less frequent. Does that make sense? Is that more clear?
Yeah, no, absolutely. That's great. Can you discuss the progression of PD dementia as opposed to Lewy body dementia, the difference between them?
Well, PD dementia does occur after many years of disease. There may be an early dementia, Parkinson's dementia, in which there are like several years, but it's like 5 years or 4 years. So during those 4 years, there is no dementia whatsoever, and then it starts dementia. Or there could be many years, like 15 years, and then there is dementia. Once the dementia occurs, that is the changes that I mentioned before, that is being more having problems with the executive function, that is the function of being an executive, right? Planning, multitasking, sequencing, having great concepts rather than being concrete, and being able to do only one thing at a time, etc. So that occurs, that is a clear change from before. And so we can have it and diagnose it by having different testing and compare the early testing with the old testing. So you don't have to compare with the general population, or if you never did a test, you compare yourself to the general population and you can see if your functioning is certainly below of what it would be for your education and your age. So that by itself is dementia. It also associates with hallucinations. Hallucinations may occur early as well. And another feature that I didn't mention much is the fluctuations. That is, some days someone can function very well and some days they may not. So really the sequence of events that is the presence of years of Parkinson's disease and then the dementia, is what is Parkinson's disease and dementia. But when the Parkinsonism occurs at the same time as the dementia, both at the same time, so we have someone that has Parkinsonism and they have also the dementia. They have the hallucinations, the fluctuations, they may have all other features as well that I mentioned before. When those are at the same time, that is dementia with Lewy body. Are those symptoms really very different? Not exactly, because when you get to be an advanced Parkinson's disease, you already have also some what we call autonomic disturbances. That is, disturbances in the urine control, disturbance in the blood pressure control, etc. So those things may happen with the progression of the illness, because at the end of the day, Parkinson's disease is not just affecting the motor circuit. Now we know that there are the non-motor features that you've heard in other talks. Thus, those features also mean that there are other systems that are involved. But initially it was thought that it was only motor. But in any case, there are features that are characteristics of dementia and Parkinsonism early on. That's dementia with Lewy bodies. And if they are late, there are Parkinson's disease and dementia. And interesting, when you look at the brain, when someone passes away, you can see that there are no differences between one and the other. But certainly the person that has Parkinson's disease and dementia lives much, much longer, because it has all the years in which they have Parkinson's disease, and then they have the dementia, and that part is what shortens the disease survival.
Yeah, it's an excellent explanation. And the last question was, what medications can cause cognitive decline to dementia? I don't know.
So medications don't truly cause cognitive decline as dementia that cannot be resolved. But certainly there are medications that do worsen the cognition. And those are medications that basically are affecting the chemicals that have to do with the memory and attention circuits. So one thing that I didn't say before is that it is common, particularly in dementia with Lewy bodies, that dementia with Lewy bodies associates with Alzheimer's disease. So when it associates with Alzheimer's disease, then the dementia looks like Alzheimer's disease. So memory then becomes very, very importantly affected. That may happen later on as well, but it's less common with Parkinson's disease dementia than with dementia with Lewy bodies. So getting back to the drugs, medications that affect the memory, that affect the attention, and for example, scopolamine that is used for when people go in a boat to try to see that they don't get vertiginous or to avoid nausea, that medication, even transiently, may affect cognition. But of course, if you take it out, cognition gets back to normal. So the good thing is that that is what we call the factors that we search that are treatable. And so those are the treatable dementias, and we always search for those. So that's why we look very carefully to all the medications that you take, because anticholinergics such as scopolamine, atropine, at times even vesicare, although ditrol is much more common and that is used as well for urinary disturbances that can also lead to cognitive changes at times, not in everybody, but in some people.
Yes, absolutely. And I think those are all my questions. Dr. Litvan, thank you so much for such an excellent question and answer. And I'll turn it over to Shelley.
Thank you, Dr. Litvan, for this excellent information. It was so helpful. I think you hit the nail on the head with all of those answers. I know our patients loved it. And just a few quick announcements before we wrap it up for tonight. Dr. Litvan had mentioned physical therapy early on in this conversation. If you are in need of physical therapy and you have out-of-pocket expenses that you cannot afford, we are here to help you. We have a fund set up with Tribe Wellness, so please take advantage of that if this is something that you're in need of, whether it's physical therapy or group exercise classes as well. Please reach out to me at info@skypassfoundation.org if finances are an issue for you and you are in need of either of those. Secondly, we are also working on a program for transportation to and from medical appointments for persons with PD. So if you have issues getting to your speech therapist or your physical therapist or your movement disorder specialist, anything that's related to PD treatment, we are here to provide free transportation. We're still working out some of the details, but if this is something that you're interested in, please let us know. It would be really helpful to gauge the need that's out there in the community. Again, info@skypassfoundation.org. And finally, clinical trials are something, again, that Dr. Litvan mentioned. That is actually the topic of our next Ask the Doctor webinar on August 17th. We are going to be covering clinical trials and the latest research in PD. So if this is something that you're interested in, which I think all of you will be interested in, can certainly benefit from, registration is open at our website, skypassfoundation.org. And if you have questions about any of the above, again, please feel free to reach out to me, info@skypassfoundation.org. Thank you again so much, Dr. Litvan. Thank you, Dr. Chitnis, as always, for conducting such an excellent interview. And thank you, everyone, for joining. We will see you next time. Have a great night.
Thank you. Thank you very much for the invite.